And so I guess I guess this is for James and maybe for Sophie. So what's the vision for this for this slice of money, which can be important, but is a declining amount in terms of the overall system?
Do you want to address this?
Well, Kathy Greenlee, our Assistant Secretary, I think in her first budget go-around proposed to double the Older American Act funding, so that didn't go very far. But, I mean, obviously, we think those types of services that are population-based, not just Medicare or Medicaid claims, are terribly important. But we're also, within our own network, saying, are these grant-based fund sources really viable going into the future? And is there a way in the health space to argue that these types of services are health-related, do bend the cost curve? Can we get the actuaries to begin to prove that? I mean, we all know that many people entering long-term care come through the hospital discharge process, go into a post-acute benefit, and then about a quarter of them end up staying as long stays, and then a lot of them spend down, and then they're part of the permanent Medicaid population. So is there a pre-dual or a care transition that community organizations could actually support that's more than just the 30-day post-hospital follow-up that is being done now? And is there maybe even dreaming a Medicare modernization post-acute benefit that would be more focused on the community care transition that could support people in that very critical period? And then could community-based organization actually provide those services? I mean, we've heard rumors there may even be Medicare codes for hospitals to build care transitions. Well, I think, quite frankly, those will be clinical, credentialed, expensive. I don't think they understand or get what it takes to really get into the community, into people's homes. So I think there's a marriage to be had there of health-related functions that really could meaningfully also bend the cost curve on the health side. But how we're going to get there, I think, is still the struggle.
On the first question, then maybe we'll have more to say about the second. You know, in terms of we've heard a lot about size and the speed and the scope of the demos. I think that one thing I'd say is that it's almost July of 2013. We announced this July of 2011. No one's enrolled anywhere yet, and the process, I think the responsible process we've been working through with states and then with health plans is to make sure that states do have the capacity to meet the need and to oversee the need, that plans do have the capacity to meet the needs of the population, and nobody will be enrolling anywhere until we fully believe that capacity is met. So, you know, we've also heard that the demonstrations are slowing down, and, you know, we just try as much as possible to focus on the fact that we want the highest quality plans and the best states to move forward, and that they won't move forward until they've reached that level of capacity and readiness, and that's the process that's going on right now.
If I could just add to that very quickly, Ido, could you say a word about the quality measures that are being developed or have been developed for the memorandums of understanding that have been signed, and how they were selected? I mean, it's very good work, it seems, to identify a more standardized set of quality metrics so that we know that plans can deliver all the services or access, you know, over on the social services side, what is really needed.
Well, there are many different kinds of quality metrics that health plans report now. They report a set of different kinds of them to Medicare, and they report a set of sometimes overlapping ones to Medicaid. So one effort was to, without sort of reducing what plans are responsible for providing, try to marry as much as possible those standards, again, without diluting them. The other thing is to focus on the standards that are most relevant to this population. Now, the flip side of that is that there are not that many long-term services and supports measures. They don't exist. So we've been working with the National Quality Forum and others to develop those. And to the extent that those are developed, and we hope they will be, they'd be brought in. And in the interim, I think we're working with the best set of core measures. Core because we want to compare across the demonstrations and compare to sort of control groups, but also flexible enough to hopefully bring in additional measures or different measures once they're developed.
Great.
Hi, Andrea Maresca with the National Association of Medicaid Directors. Thank you all for your comments this afternoon. I'd like to make one comment and then two questions for the panelists. First, I think that from the state Medicaid perspective, it's interesting to hear people say that the demonstrations, I'm going to go with the line of, continue on the line of the duals demonstrations, that it is very Medicaid focused. I think if you talk to the states, they would say that actually, if we had known from the start that we were going to be starting from the Medicare platform, it would have saved us a lot of time and a lot of headbanging against the wall for months. And then once states finally realized that actually we're starting from the Medicare platform and Medicare Advantage. So that's the perspective that they bring. And then I guess my question for the panelists are, first, there's been so much focus on California's MOU, but there are several other states and many others in the queue that have signed MOUs. So what are the promising or innovative things that you see in those other MOUs? And California is certainly an important state to keep an eye on, but there are, I think that people would agree that there are some interesting things going on in other states that could be highlighted and that the audience may be interested in continuing to hear your thoughts on those things. Second question, Javi, maybe this is particularly for you, is the opportunity to do something with the DSNP program. And that is another pathway for other states or another option for other states to pursue improved alignment and integration for the dually eligible population. So I'd be interested in your thoughts in particular and the other panelists, as well as what opportunities are there to do further, to amend that program as it comes up for reauthorization, and what is the outlook for reauthorization on the SNP program? Thank you.
I'd love to actually start with that second part, because I think that while it's understandable that so much attention is focused on the demonstration, states actually already currently have in their arsenal or with fairly standard waiver application processes an opportunity to do a lot to improve the coordination of care between Medicaid and Medicare and to sort of do their own initiated demonstrations. I mean, they don't have the kind of flexibility that Ida was talking about with respect to Title 18, but there's still an opportunity to standardize service delivery options. There are ways to create more flexibility in how services are accessed. Some states have done some very interesting things with respect to self-direction. I actually met with a family from West Virginia with a disabled child a few weeks ago, and it was really amazing sort of with a self-directed option what she was able to accomplish. She actually was able to sort of pull together all of the services that her daughter needed in a way that was considerably less costly and considerably more efficient than the sort of package that was being offered to her by the state. And I think that's where we get into some of the concern about serving such a diverse population, is you end up offering people such a comprehensive, you know, in some ways, in the better case scenario, you offer people such a full package of services that there are actually services in that package that they don't need. Which, you know, I would rather err in that direction than providing them a package of services that doesn't cover, you know, their needs. But I do think that there's still a lot of room in there to, you know, I think that the theme for many of us over the last couple of years is how do you improve care while simultaneously pulling in costs? And I do think that there's some real room in there. I do think that it's a really tricky and unfortunately an issue with a cost, a price tag, but one that needs to be addressed, that with people with disabilities of working age, we've created an incentive where it's really hard for them to get the supports they need and work at the same time. And I think I think there are some interesting attempts to address that on the state level. It may need to be done more directly on the federal level. But I think the bundled payment efforts that are being done, both federally and at the state level, I think there are just a huge number of opportunities. So I wouldn't point to one particular program. With respect to California, I actually wasn't picking on them with respect to their duals demonstration. I was picking on them with respect to their general push to put everyone in one-size-fits-all Medicaid managed care who's in their Medicaid program. I'm a Californian, although I don't usually tell the senator's constituents that, but I do have that's sort of where my particular focus on the state comes from, as I am the child of healthcare providers in California. Unfortunately, I think that a lot of the concerns that our office has about the demonstrations really are true for all of the approved MOUs, although I think some of them are doing some very exciting things. I think from our perspective, though, we'd love to see things further defined by our friends at CMS who we trust, as opposed to, it felt to us that there was a lot being left up to the plans and the states in some of the MOUs. And in some states, they're terrific and clearly seem to be looking out first and foremost for the patient. In other states, they are so overwhelmed by budgetary difficulties right now that it's hard to keep a singular focus on the patient. I think with respect to the oversight issues, all of the MOUs say some terrific things about oversight, but how does that actually get played out? And to Ito's point, part of why these aren't quite moving forward yet is there are some very real questions there, and I very much trust our, colleagues across the way to be paying close attention to this. But you look, for example, at ombuds offices. Sophie and I were chatting about this yesterday. Most ombuds offices are currently completely overwhelmed and unable to fully, sort of address concerns that are raised to them presently. Sitting at the table in front of me is a friend and former colleague who used to do a lot of nursing home oversight, and it's still an area rife with problems. The idea that suddenly these ombuds offices would be in a position to take in complaints and review and analyze complaints in home and community-based settings without additional funding is just, to me, a non-starter. So, part of what the senator has proposed is let's build into the demonstrations funding for oversight, because we're just worried that even the best meaning states and the best meaning plans aren't going to be able to take this on, especially as we move away from institutional settings.
Terrific. Okay.
Well, let me.
Sorry.
May I? To the first part, certainly some people think this is a Medicare focus, some people think this is state focused. We not everyone's going to be happy, but the fact that we're getting it from both sides, I think, indicates that we're somewhere in the middle.
Always a good sign.
But, and maybe, same thing with too fast, too slow. Again, our focus is on going when the states and when the plans are ready. I'd also say that there's no turning over responsibility to states or to health plans. What follows an MOU is a 3-part contract, and we're very much a party to that contract, and things that were left by the MOU to the contract will be specified in the contract and won't be signed by CMS unless there's that level of comfort. And even once a contract's signed, there's a really, and the second part of the question is, what's come out of this? What are some promising things? I think, I could talk about some of the additional behavioral health benefits and some of the additional, for example, in Massachusetts and other integrated appeals processes in other places. But I could also say that the process that we've built in for assessing readiness and then for working on the oversight with the states is a good model. I think could be a model for how this could happen sort of outside of this demonstration. It's something that we're proud of.
Thank you very much. I think we'll give Lee the last question, and then for those of you who'd like to stay and come up and see the panelists in person, that'd be wonderful, and we'll have coffee.
Nothing like friendships to
cookies
get.
as well.
I will defer as a host.
Okay, Carol.
Thank
go
you,
for it.
Lee. So my name's Carol Regan. I'm with the Paraprofessional Healthcare Institute, PHI, and thank all of you for your comments today. I want to ask, and in particular, I want to thank Sophie and Ahaviah for your boss's work on addressing and bringing in, when you talk about quality of care, you talk about workforce issues, and that's so important around the delivery system and financing. And I particularly, and I think, James, you talked about needing to sort of have providers pull together in their own networks to be part of these plans. Well, in some cases, some of the providers, as you all mentioned, are consumer directed, are individuals who are sort of personal care attendants, and we need to kind of look at that system that's growing and consumers want. So the question I wanted to ask, maybe Ahaviah, you could close with this, is we were so pleased that the Senator included in the language creating the Commission on Long-Term Care to say if you're going to look at financing, you also need to look at workforce issues. So could you just speak a little bit to that and the intent and what you're hoping this commission will address?
Yeah, I mean, as you know probably better than most, the workforce issues are really tricky. You have sort of the perspective that there are, well, we can start with the unpaid family caregivers and then move up from them to, some paraprofessional folks who a lot of people are concerned that they're not getting overtime, that they're not necessarily being paid, as much as we would like them to be paid. But at the same time, we talk to family after family that, if there were suddenly overtime restrictions put in, and there was not, for example, a willingness on the part of a state Medicaid program to pay that overtime, they can lose consistency in care and end up being with different sets of providers. And with this being such a personal issue, it just gets very complicated. I think we need an opportunity to air and fully discuss how to make sure people are well compensated for this important work, whether it's ultimately finding a way to also provide some support even beyond respite support for family caregivers, I think is a worthwhile discussion to look at. Certainly the people who are really in the trenches providing this work need to be recognized and need to be part of the discussion. To have a discussion around long-term care with really a primary focus on sort of the big payers in the room wasn't going to get to the issue of who is actually providing these services and what do they need to both continue the work, the important work they're doing, but move into the future with adequate protections for everybody involved. So, I think that there was a lot of hope that we would have representation in the commission that would cover a wide range of different stakeholders and really truly represent everybody who needed to be at the table. And I think by and large that has happened, and hopefully the workforce piece will be part of what they discuss. I mean, I will admit that we fought hard to get the commission extra time that I think would really be beneficial to some of these really, tricky and important issues, and so far haven't succeeded. We have some hope that based on what outcomes are delivered in September, that we might be able to make a good case later in the fall to extend the commission. But that's what I have on there.
Well, it's an absolutely fantastic start that we have here today. I want to thank all of our panelists. Please join me. And we do have coffee and cookies at the back of the room, so help yourself, and we're going to start our second panel, which should be absolutely fabulous, at 3 o'clock, and we'll dive even deeper into some of the issues we've been talking about. Thank you.
Sorry, I'm like back to the conversation.